Good evening. Welcome to our sharing experiences in hematology during SARS-CoV-2 webinar. First of all, I would like to thank you all for being here with us today. As a hematologist and medical manager at Roche, it is a privilege to have such an important panel of experts sharing their experience with hematological patients. In different realities in these SARS-CoV-2 times. I would like to thank you, the audience, that will share with us the questions. And finally, I will give the word to Professor Maria Gomes da Silva, Director of Hematology Department of Portuguese Oncology Institute in Lisbon. Thank you so much. And Professor, feel free to start this digital roundtable whenever you like. Thank you.
Thank you, Susanna. Thank you very much, and thank you for the invitation to share this change of opinions. I think, and I believe probably most of our audience knows who are the intervenients in this panel. I will start in my screen. I first see Gilles. So Professor Gilles Salles from Hospital Civil de Lyon, who is going to... Hi, Gilles.
Hi.
Hi. Then I have Dr. José Mário Maris, my colleague from IPO Porto, who will share with us the Portuguese perspective, our perspective. Then I have Professor Armando Lopes Guilhermo from Hospital Clinic in Barcelona, a great focus of COVID disease, I believe. And Professor Matthew Matazar from New York, who will talk to us a little bit about the overseas experience. And sorry, Andy, you are the last one in my screen. Professor Andrew Davis is also with us. So we have a large panel of 5 different people. And I probably would start to ask you, maybe we can start with you, Gilles, since you are the first one in my screen. Can you explain a little bit how is the situation in... we can start by your center, your city, your country, however you want to put it or explain to us, because I believe that we all have common experiences, especially in terms of stressful adaptation of new times, but the situations might be a little bit different in different places. Would you care to explain to us how are things in your place?
Yes, thank you, Maria, and hello, everybody. I think, yes, the situation is a little bit different. I think what happened in France is that the pandemic started really in the east of France and in the Paris region and spread all over the country. As many of you know, I'm located in Lyon, which is in the middle of the country. It's like the second largest city. I'm working in a university hospital, and if we look in terms of number of cases, number of patients hospitalized, number of patients in the ICU, we are, I will say, a little bit in the middle of what happened in France. The east part of France, the Paris region, is at the highest level. But if we count, for instance, the number of patients in the ICU, number of inhabitants in the middle, while people on the west of the country are still either waiting for the wave or maybe will have a lower wave if the quarantine and the confinement measures are better. So that's the first thing. The second thing is I'm in a university hospital, so part of the whole medical department, despite we are a large hematology department. And what I should mention is everything has been reorganized in the hospital, except oncology, hematology, medical subspecialties had been emptied and all devoted to COVID patients. So we were a little bit privileged to be able until now, I don't know if it's true tomorrow because everything's changed every day, to work in what I will call COVID-free environment. I think later we can discuss the details of how we have got organized, but that's presently the situation, which I will say it's not too bad, and compared to what I think in Italy or Spain in particular, which had got through very tough time in their own department, we are, I will say, relatively safe for now.
Thank you, Gilles. Yeah, this is a good perspective. And José Mario, how is it with you? I imagine it's similar to me, so it saves me the work to explain.
Yes, probably it is similar because we work in an oncology hospital, so we are not a central hospital, general hospital, and by this way we were little protected. However, we also have this experience with patients in our hospital, and as you know, Porto was in the center of this epidemic in Portugal because our connection with Milan. So we have a lot of cases from the beginning, and it is very, very hard because every day we have to think if your patient is infected or not, is positive or not. So we decide to reduce a lot our activity. We are only seeing acute patients and the chronic patients, if they are okay, they don't came to the hospital, and we are doing a lot of work by Skype, by phone, talking to the patients. But I think, at least until now, I think the situation, at least in Porto, is under control. We are very close to a very big hospital, Hospital de San João, that is the center of to treat these COVID patients. And I think the situation is under control, and we continue to treat our patients as we can.
Armando, is that how is it in hospital clinic? And we are all concerned about Spain.
Spain, maybe after Italy, is one of the countries with now with the worst situation. In Barcelona, perhaps is somewhat better than in Madrid, but still the situation for the last weeks has been really tough. In my hospital clinic is a university hospital, a general hospital, and right now roughly 90% of the beds are COVID.
Oh. And
we have preserved our area of the transplantation and the acute leukemia area. I mean, with the flow system, etc. But for the time being, we have one hospitalization area completely devoted to the oncologist patients with COVID. This means mainly hematologists. So, and regarding the intensive care units, we have at least multiplied by 6 the number of beds, because the situation was really dangerous. I have to say that 10 days ago we were in almost in the limit, but hopefully during the last week the situation is clearly better, at least in our hospital. The emergency area right now is not full, and well, it's clearly better.
Good
so we have to we tried in the last week to reduce our activity. That is easy to say, but of course you know very well that we have patients that we have to treat. So but only these really indispensable cases. No, well, maybe the specific things and how to arrange the situation is better. How to we can speak later on.
Later, Andy, how is it in your place? Kind of.
So I guess we've had in the UK about 75,000 cases, and we've had about 7,100 deaths or thereabouts. And I think we feel that we are lagging a little bit behind the curve in terms of Italy and Spain, and we hope that our quite severe lockdown measures are hopefully trying to flatten out the curve. What we've seen is that the increase has continued quite exponentially, not accelerating quite at the rate we had thought. I live and work in the South Coast, and my region is perhaps the third most worst affected areas, and the big population centres in London and Birmingham are where the biggest numbers of patients have been seen, particularly so in London. And the intensive care units are full in London, including a Prime Minister. And we have a big new hospitals that have opened as a result. In my hospital, I work in a university general hospital where we have about 1,200 beds, and I think exactly as you'd said previously, it's pretty much been turned over to activity for COVID patients. We've been very fortunate in that there is another hospital nearby, and we have been able to move all of our oncology and hematology practice into what we call a cold site. So essentially we are practicing oncology and hematology perhaps at a lower number of patients that we're treating because of risks, which we can talk about later. But we have been fortunate to be able to keep them on a clean site where there's no acute admissions. Our number of ventilated patients in our hospital this week has remained pretty stable. We've got about 20 or 30 patients who are being ventilated for COVID, which is not a huge number compared with the numbers in Spain and Italy, but the numbers in London are somewhat bigger than that.
Thank you. And Matt, how is it overseas? How is it in New York?
So New York has obviously been the American epicenter of the COVID crisis. Working at Memorial Sloan Kettering, we've been a little bit spared from some of the ravaging that our sister hospitals in the city have experienced. Since we're a private freestanding cancer center, we don't have a public-facing ER, and thus are only taking care of mostly of our own patients. That being said, we've had to, like my colleagues have already said, reinvent how we do cancer care in a very short period of time, both in the outpatient as well as inpatient spaces. Outpatient-wise, we've converted to over 95% telemedicine, where we're really trying to limit patient encounters, both for evaluation as well as for treatment. Inpatient-wise, the majority of our hospital right now is COVID, but we have not run out of ventilators. We've actually been able to lend a few of our spare ventilators to Weill Cornell, which is just across the street from us, but has a public-facing ER. Our curve has been flat. We've been stable in the number of ventilated and admitted patients over the last 3 days. It's not clear whether this is just going to lead to a more protracted course that's going to require a more prolonged adjustment of how we conduct clinical care, or whether we're actually going to turn the corner. But these next 2 weeks should be informative.
I think one of the questions that everybody has, at least I have, and I would like to hear your experiences. I believe that all of us had to reorganize the way we take care of patients, regardless of choosing one or another regimens for one or another disease. The way we take care of patients has been changing, and here in my place is changing like every week we have to change something else. Every day we have to change something else, which is an effort more than the work. So you already mentioned that you change the way you you follow a lot of patients, and you do it as telemedicine or whatever. Any other changes in organization in your center?
Top to bottom, there's been change. I mean, this is the one truth of practicing medicine at the time of COVID, is the hospital will look different today than it did yesterday, and will look different tomorrow than it did today.
Absolutely.
So much of what we're doing is about trying to keep patients safe, trying to keep our staff safe, evolving management of trying to reduce or prevent nosocomial spread, and managing patients during the course of their COVID infection, during convalescence. There's nothing but change and challenge right now that we're facing.
Actually, a question that this organizational question is common to all of you. I don't know if anyone wants to comment on other changes that are being implemented in your centers. Andy, yes, please, Armando.
Regarding outpatients, we try to omit all just the control visits.
Yes.
And of course, those patients on therapy have to continue with the control, but all the others. And we are trying to do phone visits. That sometimes is not so easy. In some cases, we need, not only in the lymphoma setting, I mean, but sometimes you need at least the analysis, so the patient has to go to the hospital to have the analysis. But, well, perhaps now in the outpatients, we have maybe 40% of the patients that, oops, sorry. And then regarding the inpatients, as I told you before, we design a specific area for COVID positive patients with hematological diseases. By the way, we have a full, it was full, this area, even with patients ectopic, so in other areas of the hospital. Yeah. But it was very convenient, at least to have because the management of our patients, even with the COVID, is somewhat particular, and in general, the general doctors are not comfortable with them. So for them, I think it was important, and we try to preserve the Sancta Sanctorum, so our area with the allogeneic transplantation, some CAR Ts, some bar kits, whatever, and then in this area preserve.
Yes. Any other comments from Gilles? We want to comment on your reorganization.
Well, sorry, I got disconnected for a couple of minutes. I have tried to get a place where the Wi-Fi was better. I don't know if it's a little bit better.
It is.
Yes.
Yes.
Okay.
Yeah.
So I can't really comment. I can just say what has been a little bit organized. What we have done for hematology patients like everywhere, like protective measures for all the people working. Everybody working in the hospital is working with masks and all the usual precautions. What we have done is for patients coming to the outpatient clinics, we have called all the patients the day before to make sure they didn't have any fever, any respiratory symptoms and things like that. And if this was the case, we have organized a specific place to screen them, which is separated from the patient visits. There's only one box where we can actually see this patient and sample this patient for the virus by nasopharyngeal sampling. Initially, there was a lot of reluctance from the hospital because, like in several other countries, there was not enough tests. So they were a bit worried that we'll test too many people, but we managed to find our way in this limitation. So now we have that organized. Obviously, it's not absolute, and I just heard this afternoon that one patient that was hospitalized actually for a few days. Unfortunately, he was found to be COVID positive 3 days later, so it happens. But this has probably limited a little bit the possibility to spread the virus. For patients that are hospitalized, we have only screened patients for transplant, and we start to screen more regularly patients for leukemia, for acute leukemia. And regarding our practice and activity, we have delayed a few transplants, such as first-line transplant in mantle cell, transplant in multiple myeloma. We have withdrawn dexamethasone from all myeloma patients who appear to be the patients that they most unfortunate to this. We have lost 2 multiple myeloma patients, which were in first line patients in the range of 55, 60 years old. So that's what we have organized, but I guess other people have also other activities to it.
My experience in my center is quite similar. That's what we did. We tried to, the day before the patient is scheduled to come to the hospital, we usually talk to them on the phone, just checking on symptoms, and we try to separate those patients who have symptoms from all the others. So separate the circuits and try to avoid as much as possible that those patients get mixed with the others, assuming, of course, that we are efficient on doing that. Some patients just don't say it and just come and come into our offices, but that happens. And I don't know, Zé Mario, how is it with you? Are you doing the same?
Yeah. More or less, we have a nurse at the main entrance of the hospital that is seeing the patients and check the temperature. And if the patient has some symptoms or temperature, so the patient needs to go to another place specific for COVID patients to make the screening. Yeah. And we are performing the screening to all patients that has to stay in the hospital, even if they are asymptomatic. Okay. Do you know that now there is some our authorities said that we should test all the patients before the treatments, even if they are asymptomatic. But our administration said that we have no possibility to do that because we have no enough tests, because it would mean more than 300 patients every day. So it's almost impossible to test all the patients that are starting treatment in the out clinic. No. Are you doing it? Or?
Actually, it was my nightmare by the end of last week. This recommendation from our health system to test. It's not testing before treatment. It's testing before each cycle of treatment and during treatments, like every week for patients on continuous treatment. So it's obviously it should not be a matter of concern because we don't have the capacity to respond to that. So we had to make some options, and those were quite similar to what Jill was saying. Actually, we are testing all the patients before aggressive regimens like for acute leukemias, Burkitt also, and salvage regimens like DHAP or ISHAP. We are testing before. We are testing patients when we admit them electively to the hospital for treatment. And part of the tests, I think, are on behalf of the peace of mind of our nurses that are a bit nervous about the pandemics. I'm not really sure that we would need to test so many people. I think we will learn a lot with this rule, but of course we are not testing patients on a regular basis.
And probably we should test on regular basis the professionals. Because at our hospital, I just saw the numbers. We found 13 patients and 24 professionals that were positive. So it would be much more effective if you test maybe every week the doctors and nurses and everybody in the hospital.
I think Andy was making a comment.
I was just so unfortunately in the UK we have a serious lack of capacity for testing, and this has been done on a centralized basis, unfortunately, and we're somewhat behind the curve. So in fact we don't have enough testing capacity even for members of staff who are off sick. The only testing we can do is testing for people who are in hospital with COVID symptoms. Okay. We can't do any testing in the community either. So there's a great push to ramp up testing, but there's a great shortage of reagents. There's not insufficient numbers of machines, etc. There's a real barrier for us to be able to do this. So in terms of our patients with hematological malignancies, those patients are the only people that we can test, and are the few numbers of patients who are going forward at the moment to have allogeneic transplants, and it's just those individuals that we have the capacity to test, and it's all been regulated on a central basis coming from our national body, which is called Public Health England. Okay. So kind of on some of the other things we've just talked about, the way we practice is very different, and it's challenging. You know, as Matt said, we're pretty much moved 90% over to telemedicine, teleconversations, video linking with patients. Trying to video link with an 80-year-old is often challenging, but really I think that trying to assess patients over the telephone is quite a skill. I think that we don't necessarily get a feel for the toxicities. I think we don't get a feel for response assessment, and at the moment, whilst we're in the first 6 weeks or so of this, I think that's okay. But actually, I think as we have people who are seeing less and less of as their cycles go on over the months, that really worries me that you don't get to look at the whites of their eyes, really. Like many of my colleagues have said, we are phoning patients before they come to the hospital to make sure that they are symptom free, and then they're checked again actually at the front door as well. So we have a sort of a double gate to stop symptomatic patients coming to us, and we have a specific route of a pathway for those patients who are symptomatic. We've been really lucky in that there's been a huge number of volunteers, so it means that we've been able to go largely to people's homes to do their pre-chemotherapy blood tests, which means that they're avoiding having to come to the institutions, which is great, because of course we want to cut down on the footfall. And we've had to do quite a lot of rearrangement in the clinics, really to prevent, to separate people, the social distancing, to keep the flow of patients right, and really just making sure that we're keeping our staff safe, and that we've been able to provide the appropriate PPE for the personal protective clothing for everybody. And this seems for us to be changing on a week by week basis, and the rules seem to change faster than we see new cases. And we're all, 1 minute the rule is that you wear this, and the next minute the rule is you wear that. And being able to maintain the stocks of those have been challenging for us. I think our inpatient activity has significantly decreased. I think we are doing less, we're doing less autologous transplants. So the ones, the myelomas, the low-grade lymphomas, those kind of ones where the benefits are more marginal, we're doing less of, but we're continuing to do those for the the few people with large cell lymphoma and the Hodgkins disease patients that come through. But I think our autologous transplant activity has fallen dramatically. Of course, we're still giving reinduction therapies and new therapy, the therapies for Burkitt's patients. Our trial activity has completely ceased, and we're not recruiting anybody to trials, and we're not treating anybody with CAR Ts because we can't afford the pressure on our intensive care units.
Yeah, we just as a comment, we in my institution, all transplant activity has stopped 3 weeks ago, and that was a decision, let's say a preemptive decision, because we still have the means to do it, but people were afraid of the shortage of blood supply. and intensive care unit beds. So we also stopped the CAR-T program for the time being, although in Portugal the situation is, of course, the number of cases is increasing, and number of deaths also. It's still under control, and our intensive care units still have some capacity, especially in institutes of oncology like mine and Jose. We are quite protected until now. So we will resume the autologous transplant program, but not the allogeneic for the time being, at least until we are more sure about the trend of the numbers. What about transplant in New York, Matt?
We too have markedly curtailed our cellular therapy programs.
Yeah.
Autologous, almost none. It's interesting that Hodgkins was listed as one that's still ongoing. We've largely deferred our Hodgkins transplants and are simply extending salvage therapy programs and trying to use less intensive salvages that can be protracted to try to defer consolidated transplant in those patients.
Mm-hmm.
CAR-T has been halted. Clinical trial therapy is ongoing, but we're placing very strict constraints on what patients we can put on trials.
Mm-hmm.
We're limiting trial activity to only those trials where the standard of care is simply unacceptable, and the trial therapy would be expected to have a significant impact on survival.
We also altered inclusion in clinical trials. I was a bit against that. I can understand the philosophy. I fought a bit, but actually those were the decisions of the hospital. Gilles, how is it in Lyon? Are you still able to keep a clinical trial program active?
I think we are a little bit in the same situation like in New York MSK. We have essentially maintained trials where these are early phase trials with compounds that have already shown some specific activity for specific groups of patients, for instance, bispecific antibodies or a few drugs like that. I have to note that a couple of companies, such as have also halted their trials.
Yeah.
But besides that, we are still accruing a few patients, but randomized trial asking a question which is really unknown. I think we haven't recruited anybody unless there is a very innovative agent here. But standard trial like that, we have recruited patients. Similarly, we had a larger observational program which we have halted just to keep. Most of our clinical research group is working from home. Hopefully, the hospital was organizing all these connections. They connected, I think, almost 700 people from to work. So administrative assistant, people are working from home. We have like maybe one fifth only or 1/10 of the people usually attending the hospital that are here. And I think this is very important because the virus is everywhere. The less people come in the hospital and have an opportunity either to meet with patients, but to meet with professionals, or to put their hands on everywhere with virus, the less likely you have to have either a health professional or patients contaminated. And I think this is important.
Yeah. Yes, I understand that. Is that the same with you, Armando? Did you also?
Yeah, exactly the same. The number of new patients in the trials were almost stopped, and also the allogeneic transplantation program, and particularly the CAR-T cells.
Yeah.
Because in our country we were in the edge of about the intensive care units and the ventilators, and we were 10 days ago with the point of the therapeutic ceiling of each patient.
Yeah.
And this means that a patient included in a clinical trial, whatever, apparently he or she didn't deserve to be ventilated. So the situation was very, very, particularly our colleagues in Madrid, they have this kind of real problems. In our hospital, I have to say that we haven't arrived to this situation, but it was really terrible. Particularly other doctors of other specialties, with the idea that hematologist or in general oncologist patient, of course, he or she doesn't deserve this ventilator because the possibility that the expectancy of life is so low, and of course, and it has been a fight against these ideas. Because I mean, a patient with a diffuse large B-cell lymphoma in CR has an expectancy of life like another person. So this was a big problem.
Yeah, I think we pretty much all share the same type of experience. I believe that at least as in Portugal, I don't know if José wants to comment on this also. I think we acted more as a prevention than as a reaction to a crisis, because we still don't face a very dramatic situation. But at least in terms of intensive care units beds, but we did react the same way like 3 weeks ago, and we halted pretty much all the activities who could challenge the care of the infected patients. Zé Mário, can I ask you, did you change? You were saying that you kept most of your activity focused on acute patients.
Yes.
Did you change any treatment protocols? I mean, are you avoiding some regimens? Are you avoiding treating some diseases? What are you doing?
Yeah, for acute patients, no, we didn't change any protocol. Of course, if maybe if you have to choose between a BIACOP or a BVD for a Hodgkins stage 3 or 4, of course, we use a BVD.
Yeah.
But the others are DAP or ICE, HCV, we are using the same protocols for acute patients.
Mm-hmm.
Yes, we for chronic patients we decided to stop all the maintenance treatments, like in follicular or mantle cell lymphoma. We stopped that kind of treatments.
Is that a common? I mean, is that a general feeling from all of you? We are mostly people focused on lymphoma care, I believe. So, what about maintenance? Gilles, I have to challenge you. Are you still doing maintenance, or did you give up maintenance?
So we had discussion in the department regarding this issue, and we decided to do that on a case by case. For each patient. I saw 2 patients this morning that were, rather follicular lymphoma with quite an aggressive presentation that were in their first year of maintenance. We have kept those. We have cancelled a few in the second year and things like that. I think it depends also if the patient comes from far away and things like that, and how long it's organized. Obviously, with sub-Q, it's rather rapid, so it's not a major issue. But we decided that most of our indolent patients should be postponed in the last 3 weeks. But apparently now it seems that we are entering a plateau. We were fortunate not to be in the situation that Armando described, but we are entering a situation where it's going to be like that for probably a couple of weeks. So we may reconsider that. I think the question of having patients to come to the hospital, you expose the patient to possibility of being contaminated. Regarding the immunosuppressive activity of rituximab and sensitivity to viral things, I think when you do R-CHOP, it's true for 1 year, and if you skip 1 or 2 maintenance, I don't think it changed anything. So I think it's not a major thing. And we discussed last day a new patient that had COVID disease 3 weeks ago, and how do we treat this patient with aggressive mediastinal lymphoma, a young lady. And we decided to treat her as we will do usually after talking with the infectious disease colleagues, who advise to do as usually 3 weeks after her symptoms have resolved.
Thank you. Any other comments about maintenance?
Yeah. I mean, I think that first of all, I think in low-grade lymphomas, we've raised the bar a little bit in terms of the threshold for initiation of treatment, and I think we've delayed some people that we would otherwise may have had a different threshold for treating those. I think that we shifted quite a lot towards bendamustine treatment in the UK. We use a lot of bendamustine frontline therapy. I have grave concerns about using bendamustine in the era of COVID, and for those few patients that do need treatment, we've gone back to good old-fashioned CVP that we've known and loved for a long time. The other thing to say is for maintenance, yes, we have generally suspended maintenance, not stopped it, but generally suspended it and said, look, let's come back to this when the peak is over. I think Gilles' point is absolutely right that these patients are likely to have B-cell depletion for a long time rather than just simply for us to deplete, to suspend the maintenance over a period of short period of time. But I think the other thing is the risk of the small number of patients that we see who have neutropenias with maintenance, and I think we just want to give them the best chance. So I think our view has been a suspension of maintenance with a plan to review everybody when we're over the surge.
Some people are writing, at least, or discussing extending the period between administrations, like 3 months instead of 2, or delaying the start of maintenance. That's at least what we've been doing. People who are already under maintenance, we are doing maintenance, of course, if they don't have clinical problems. For the elderly population, we are thinking a bit differently, and we are mostly interrupting maintenance because they are at a higher risk. Same for you, Armando?
Well, regarding maintenance, yes. In general, the idea was to skip any not important maintenance. So, with the exception of mantle cell lymphoma in general. But anyway, I'm not really convinced that this is very important. Because the problem probably for these patients is the respiratory failure. That means this hyperinflammation. That I have the idea that maybe our patients globally are quite protected from this. In fact, we expected a higher mortality in our patients, and I have to say that, of course, we had some patients that have died, but in general, in the elderly and those people very heavily treated, etc. And regarding lymphomas, with the exception of one patient that was in the 70s, that was in the treatment with R-CHOP, but most of the others at the end can be the discharged from the hospital in good shape. I mean, our first idea 1 month ago, with the idea that all the patients COVID positive with hematology disease are going to die. This is hopefully this was not the real thing. And
Armando,
there are other for instance, in the myeloproliferative diseases that is not our field, but we had the doubt about the imatinib or ruxolitinib. And we decided, no, we have to keep this. And after that, Ruxolo, for instance, can be used in the therapy of these patients. Mm-hmm. And the same is regarding ibrutinib. There are some trials and other drugs.
Andy, you were going to ask
I was just going to comment on that. Really, I think we came into this from the Chinese experience, the registry experience, with really terrible expectations in cancer patients. You know, they were very small numbers, but actually the outcomes were, you know, were very, very poor. And actually, I think that gave us, and it gave our intensive care colleagues, a very warped view of this. And actually, I think, as you say, Amanda, we are seeing people, you know, with hematological malignancies having chemotherapy, who are having treatment, you know, who have COVID and are getting better and being discharged. So I think that there is a warped perception because of the original papers that came out of China.
Yeah. Matt, do you have any comment on that? Any particular specificities on the clinical course of our patients?
The clinical course, it definitely has been interesting for our lymphoma population. Mortality rates, as you've heard, have not been as high as we've been originally concerned. We are seeing now starting to develop a small cohort of patients with what is becoming somewhat chronic COVID infection, particularly patients with hypogammaglobulinemia due to lymphoma and its therapies. Mm-hmm. I have a collection of patients in my personal practice who have COVID, who have now been continuously shedding virus with continuous symptoms for 4, 5, 6 weeks.
Wow.
Not so sick that they've been hospitalized or intubated, but with chronic severe viral symptoms of daily fevers to 102, 103 Fahrenheit, myalgias, cough, and not clearing their virus. And we are going to need to figure out how to manage these chronic infections with COVID in immunocompromised hosts soon.
Yeah. Is that the same experience for all of you, or because I have to say that in our practice we saw until now 3 COVID positive cases. One was a myelofibrosis who actually died in a very short time with acute respiratory failure. But I have 2 CLL patients actually not under treatment, and who have been diagnosed 1 and 2 weeks ago. They are at home and they are, you know, they have flu symptoms, but they're nothing really serious. It's a very short experience, so I don't really know what's going on in larger populations.
Our experience is also very short. We also have 3 patients until now that I know. One was multiple myeloma, and the patient was under treatment with BMP, and after, I think, 3rd cycle, pneumonia, intensive care, and diet. And another patient was with a follicular lymphoma, and she had febrile neutropenia after the last cycle, 6 cycles of R-CHOP. And at the end, the fever persisted for 2 weeks, and we tested, and she was positive. She was ventilated for 1 or 2 days and recovered. Mm-hmm. And another patient with CML that was under treatment with imatinib also got the disease, but also recovered after two weeks. So it's our experience with COVID until now in Porto.
If I may, I think the death rate in hematology patients, we are collecting all the patients from the department, is in the range of 20 to 25%. So it's quite a high death rate. Mm-hmm. We didn't have, I think, any patient with lymphoma dying. As I mentioned, it was multiple myeloma, 1 very old CLL, 1 patient with immune neutropenia, which was not that neutropenic and was in very good shape. Mm-hmm. And I will say that the multiple myeloma that died, as I mentioned, there were 1 patient at least with like the 3rd cycle of VRD induction. So that's not very terrible multi-organ failures with infection. So that's the reason we suspected dexamethasone to be probably favorizing the infection and the course of infection. Although again, nothing is proven and we don't know yet. But 20-25% death rate for documented case, I think it's unfortunately much higher than the general population.
Yeah, it is, and maybe with other risk factors that maybe by sharing our experience we can get to know other risk factors for our patients, like dexamethasone, like corticosteroids in multiple myeloma, or any other drugs that any of you would avoid in this. I mean, I share Andy's opinion on bendamustine. We actually are giving up bendamustine more and more, low-grade lymphomas, and we're using RCVP also, or R-CHOP. That depends on the presentation. Any specific drugs that any of you would avoid at this time in our patients?
I just echo the Hodgkins discussion, really, that we have used much less BIACOP and pretty much give everybody ABVD. Okay. In those cases of very high risk disease, we have abbreviated the amount of steroid we've given in the BIACOP regimen. But there's been very few patients that we've had to do that, had to give BIACOP to. We want to try and avoid that completely.
Mm-hmm. Matt, you were commenting on salvage regimens for Hodgkin a while ago. What are you using?
For salvage, we're trying to use as much mild salvage as possible. So brentuximab monotherapy or BV plus Nivo. Okay. We're trying to avoid ICE or chemotherapeutic regimens, both because of resource utilization as well as immunosuppression.
Okay.
For first-line therapy, we haven't had a lot of first-line patients with COVID yet. I actually have my first who was diagnosed just before starting induction, so she hasn't yet started with me. Yep. There's reasons to be worried about bleomycin in general and its potential to add to the toxic course of a COVID infection. So for her, I'm actually entertaining using brentuximab plus AVD, although I don't often use that as an induction program, simply out of concern regarding cumulative pulmonary toxicity.
Yeah. What about radiotherapy in Hodgkin? Are you using more chemo and avoiding radiotherapy in localized disease? Because I was thinking about medicinal involvement because of concerns of toxicity, lung toxicity.
It's a fair question, and one that I haven't yet had to grapple with for an individual patient. Mm-hmm. Our radiation oncologists have also changed the way that they practice, and I'm not sure if that's consistent across institutions, but they are working to markedly reduce their length of time and exposure to their patients. Yes. And so, 15-day treatments have become 5-day treatments, 5-day treatments have become 2. Instead of boom, they're doing boom. Yeah. We're really trying to limit the amount of time the patients are spending under the LINAC.
We're doing the same. I don't know if it is general, but at least in Portugal is in my institution is like that. Yeah, they are reducing the times. Yeah.
Well, what I can say for elderly patients with indolent diseases is that I think in the last 2 weeks I have prescribed oral carboxylase agents to just delay the time to discuss the case a little bit more in depth in a few months when hopefully the situation will be better. Yeah. I hadn't done that for quite a while, I will say. So, and we have recommended that to a few patients with indolent disease that needed to control a few symptoms, but we did not want to start anything else.
Yeah.
So I guess one thing I've done differently as well, just in one case so far, is in mediastinal lymphoma. I've always been a great believer in the fact that there's no evidence base yet to omit radiation. And although we do see case series that suggest that PET negative patients can readily have safe emission of the radiotherapy, I've been a great believer in waiting for the randomized evidence, and that's what we've been trying to achieve in the ILSG 37 study. But I think actually in these times I haven't committed patients who are PET negative to mediastinal or consolidative radiotherapy and PMBL based upon the case series rather than just any great evidence.
Yeah. So you're doing R-CHOP and PET negative.
Then stopping.
Yeah.
And the other thing I guess we've done differently is we've really raised the threshold for CNS prophylaxis in large cell lymphoma. And I think we want to keep patients away from the hospital. And although our practice had moved very much to the delivery of IV methotrexate intercalated with R-CHOP, we really don't want patients in the hospital. So we've only given IV methotrexate to those patients at the highest risk because of renal or testicular involvement.
Okay. Yeah, that's a good point. I've been discussing a case which is kind of a borderline case. And was exactly like that. I would avoid it. I mean, we are not sure, so I would avoid it.
And I just don't want them hanging around the hospital trying to clear methotrexate, basically.
Absolutely. Any other specific comments about regimens or things that we should or we might think about changing in our patients?
I was interested to know what everyone's view was about checkpoint inhibitors in Hodgkins.
Who wants to start?
I think we have a very few patients on checkpoints right now. I think we haven't stopped those. I think there is a clinical trial starting in France in cancer centers using actually checkpoints, so to reinforce the immunity of this patient. I don't know if it's wise or not. But I just learned that this morning that there's we have very few patients. They got benefit. I have halted one patient, which was actually very specific after CAR-T, so without any proven benefit, I will say, a primary mediastinal. But besides that, the Hodgkins that have failed, we may eventually give the drug at longer intervals, because I don't think we need the drug every 2 weeks or every 3 weeks. But besides, I think these are patients not in very good shape, so I think we should probably not withdraw too much care for those.
I still have no experience. I mean, we did not stop using it. I think sometimes about pneumonitis, but pneumonitis with bleomycin, with radiotherapy, or with anti-PD-1, we have to take some risks sometimes, so if it is important.
It makes the differential difficult, though, doesn't it, when you see somebody with pneumonitis, and whether that's COVID related or whether it's related to your Nivo Pembro.
That brings me to the level of suspicion that we nowadays all have about all types of symptoms. I mean, if a febrile patient comes to me, if it were 1 month ago, it would be febrile neutropenia. If it is today, it will be COVID before I can rule it out. So it's a completely different way of approaching our patients.
Nowadays, when we have a patient with a minimal infiltration in the lung, we have to assume that it's a COVID.
And even if there's some cough and your nose is clotted or something like that, you probably will have to test if it is important.
And in most cases, it's true.
I think if you have no specific comments now, I'm just taking a look on the questions I have here on the board, and I have questions from different parts of the world, and some of them are not identified, which is not that important. First question here is for everyone. Do you think immunoglobulin could mitigate the superinfections in hematological patients with SARS-CoV-2 positive?
I don't know the answer, but there were some recommendations by the EHA, European Hematology Association, actually regarding different drugs, but also regarding immune prophylaxis. Obviously, they won't prevent COVID because nobody is immunized, or very few patients are immunized. We know there are clinical trials going on with plasma from patients who have recovered from the disease, who are are being treated with serum from this patient, plasma from this patient. But regarding immunoglobulin prophylaxis, I think it's probably wise to maintain it for this patient to avoid the super infections in this patient if they have lung disease. I don't know. That was what was recommended.
Yeah, I read the recommendations from EHA. I saw the same thing, and I have to say that I'm insisting with my patients when they say they don't want to come to the hospital, and I understand, I'm insisting in immunoglobulin. Of course, we know that it's not protective of COVID, but it can protect against other complications for now. Any other opinions on that? I have another question here, and this is from José Cabeçadas, the pathologist in my center, who is not in my room here, he's probably at home, but he sends a question about what's the impact on biopsies for the first diagnosis of lymphoma. Of course, that's what he thinks about. Do you think it's wise to switch to core needle biopsies? And if so, what will be the impact for the final diagnosis?
Maybe sorry.
Go ahead.
Well, no, the first point is that the incidence of lymphomas apparently has decreased during the last month. This is so. After, I'm afraid that in the next month, we will have many of them. And then the real thing is that with all the hospital with the COVIDs, to have excisional biopsy has been difficult for the last weeks. So it's true that maybe we have a higher number of core biopsies with never a fine needle, but just a thicker needle. But at least in our cases, the diagnosis is more or less like always. We try to do that.
Except that it's really difficult to obtain a biopsy these days because surgeons are somewhere or are busy or we cannot find them.
So our surgeons are running the COVID wards because all their operating theatres have been turned into ITU. So all their anaesthetic machines are being used, and literally the surgeons are running the COVID wards. It's quite bizarre. So we've had to shift much more to core biopsies, much as it pains me. But that's where we are.
Yeah. True. Yeah. And now I have another question asking about if any of you has any experience on the management of COVID-19 positive patients with non-Hodgkin lymphoma on R-CHOP. The concern is leaving a patient on chemotherapy while treating the patient for COVID. Trying to balance risks and benefits. If you have a positive patient, should you continue? Or should you interrupt and for how long? I think that's the point of the question,
Our experience, if a patient is positive, in my opinion, you have to stop the treatment of the lymphoma, with the exception if the patient is dying because of the lymphoma, of course.
Of course.
In this case, we thought about and probably just a dose of cyclophosphamide or whatever just to stop. But with an active infection, in my opinion, you have not to treat the patient. And if you have a patient with lymphoma, with the COVID positive, and after not positive, I mean with the disease, when to continue? We have a sort of protocol in-house, and after the discharge of the patient with a negative test and then asymptomatic, we perform another test in a couple of days, and then not before 2 weeks, 14 days, we will restart. And I'm talking about a patient that needs a therapy. I mean, not an indolent lymphoma or whatever. That's our our guideline.
Yeah. Is this a general practice? I mean, waiting for, I don't know, second test and 2 weeks, 3 weeks, 1 week, something, are you doing all the same way?
That's been our approach in New York, is waiting 2 weeks and waiting for a negative test before resuming therapy, unless it's critical. Yeah,
yeah, I think so. I don't have the experience yet, but I think it sounds very reasonable. I have another question here. Actually, I think it's from Memorial. I'm not sure about the name of the person. So, Matt, this is probably for you. For mantle cell lymphoma, frontline, any thoughts about what regimens might be better in the next couple of months?
I think the question is from my colleague, Dr. Botlevy, who's texting me in parallel with this conversation.
Oh, sorry.
So we're all figuring this out in real time. But you know, how best to induce someone with mantle cell lymphoma right now is an open question. I would say that my personal bias would be to try to defer induction therapy if possible. We know that these patients can often be monitored for a measure of time without impacting subsequent course. If somebody were to require primary therapy, then I would probably treat them with the intention of figuring out what I'm going to do. Are they going to be a candidate for upfront intensified approaches? And if so, I would probably start with R-CHOP chemotherapy. I would try to avoid bendamustine-based therapy if possible. So if they were going to be treated with a more conservative approach, I might choose an RCVP.
Would you use RC or DHAP alternating with R-CHOP, or?
We would normally do something RSC based. Right now, our hospital beds are extraordinarily constrained.
Yeah.
So I would not be able to use an inpatient chemotherapy program.
Okay.
I would probably start with whatever I could outpatient wise, and probably start with R-CHOP, deferring the cytarabine based for later in the course of induction.
Okay. Zé Mário, are you doing the same, or?
Yes, we are using R-CHOP right now.
I have to say that we are using R-CHOP alternating with our RC or DHAP. We did lower the dose of our RC without any basis, I have to say. But we use the dose of the Nordic protocol, and we reduced it to 2/3. What's the view, Gilles? What's your view on that?
So I think we'll very likely avoid Banda. We use sometimes in elderly patients. We use a lot of RSC, and RSC and platin salts, mostly oxaliplatin rather than cisplatin. We have continued to do that. We have a few patients in treatment right now. We again try to not give too much dex for these patients, but we have continued that and continue to use R-CHOP when we felt it was an option for R-CHOP in 60, 70 years old patients, or patients not necessarily going for transplant.
Yeah. Andy, any?
Yeah, no, very, very similarly. You know, we were quite wedded to bendamustine for patients who are older. We've changed that to R-CHOP stroke RCVP. For the younger patients, we're doing the same induction regimen. However, having given just 1 day of our cytarabine rather than several, just reducing the dose. And the other thing we have done is to cut the autograft off the end of the Nordic MCL2 regimen, and we put that as a low priority procedure, and we certainly haven't proceeded with that as we would normally have done. I wondered if any of the colleagues have thought about using BTK inhibitors in the frontline setting in the older population.
Any comments? Now it's for you, Armando. I mean, it's for you, taking into account the results of the trial on the indolent mantle cell. I know it's not the same thing, but it's...
No, because in indolent mantle cell, you have to do nothing nowadays.
Do nothing.
Do nothing. For the time being, for sure.
And in these in symptomatic patients, we are not allowed to use Ibru in first line, so we have not the opportunity to do that. And in fact, we are doing, as Gilles said, exactly the same therapy for those patients already started the treatment. We are deferral in a couple of cases we have with mantle cell lymphoma, but not so symptomatic. We are waiting for a while until the peak of the disease.
Yeah. Andy, and are you using BTK inhibitors first line?
We have a trial that we're running in the UK, frontline, the Enrich trial.
Yep.
And that's a useful trial to have available at this time, but of course it's a randomized study, so you take your chances, really. Yeah, it's true. Actually, I had a question regarding using new agents frontline, but that would be in CLL. Have you think Portugal has a special situation? We don't have approval for ibrutinib first line in CLL except for the high risk genetics, meaning del17P or P53 mutated. So we still cannot use it frontline easily. But these days, would you think about using like venetoclax or obinovenetoclax or R-venetoclax, I don't know, first line in more fragile patients?
Nobody.
I think it's very difficult to answer. I mean, depending what you have access to. As you know, there was this idea that eventually, because the very severe symptoms of COVID disease, SARS-CoV-2 infections are related to a kind of a cytokine storm, maybe based on the observation of CAR patients. BTK inhibitors may prevent that, but I don't think this is based on any solid observation. It's more hypothetical idea regarding the role of BTK in macrophages and things like that. I think yes, we started a few patients on venetoclax rituximab recently, but not necessarily in first line patients that needed to be retreated and things like that. So I think you can more easily and we probably are more permissive regarding GCSF use to avoid leading patients to neutropenic, and I think that's important for all our patients to keep higher counts of neutrophils if possible.
Here another question regarding on how many weeks a suspected patient of COVID-19 must be isolated if he doesn't have any symptoms. It's not very clear from the question if the patient is positive, but probably it's a question regarding a suspected but not confirmed patient in a situation that you cannot confirm it. How many weeks should he be isolated if he has no symptoms?
In Portugal, 2 weeks by law. No?
I know.
But I'm not sure that it's enough.
I know. And with this experience of patients being symptomatic for a prolonged period of time, more than the 2, 3, or 4 weeks that we heard before, I'm not sure there's a correct answer for this. I don't know if anyone can help, but
I mean, we have the same rule for 2 weeks. We know that people continue to shed beyond that. So I think it's difficult to answer that question.
Yeah. Okay.
As I said, we just discussed the case recently with this primary mediastinal with a group of ID people, and we have actually in Lyon one of the virologists who is being involved in the kind of French scientist committee trying to give opinion to the government. I don't know if he's more wise because he does that, but let's imagine this is the case because he interacts with a few other people. So yes, the patient didn't have symptoms. 2 weeks was supposed to be fine. We took another week of safety. She has been tested negative 2 weeks ago, and they said you can start the treatment. We know it takes some risk, but it's probably also we take risk of not treating her. So when the patient doesn't have symptoms, are less likely to excrete the virus. My understanding is that the long-term expressions are mostly symptomatic patients, from what I have heard by our colleague from infectious disease.
Yeah. I have here another question about Waldenstrom's. Does any of you suggest any changes in the protocols for treatments, I imagine maybe first line or any other lines, on Waldenstrom?
So again, my suggestion is to sit it out for as long as you can do.
I do.
Unless you really need to. And you can often do that with Waldenstrom's.
Yeah.
I worry about the amount of dexamethasone in DCR.
Yes.
I haven't had that circumstance at the moment, but I would certainly consider giving without the steroid.
Yeah. Giving I actually I'm doing this in an elderly patient at this time who is an old lady, very old lady, bad shape, but she really needed treatment. She had hypervascularity, and I'm just avoiding corticosteroids, just using cyclophosphamide and rituximab. So, yeah. No other good suggestions?
No, I have one very elderly woman who I have not treated for many years, who unfortunately developed acute hemolytic anemia some time ago. So she came for us second or third course of DCR, and we give it without DEX, which is a little bit specific for patients with anemia, but we thought, okay, maybe we take cyclophosphamide will be enough, and we don't want to take risks.
Good idea. And another question. Oh, this is really difficult. For relapse, high-grade and Burkitt lymphomas that require autologous, is it recommended to defer the transplant?
So we have published nice guidelines on transplantation in the era of COVID. We have put high-dose lymphomas as a high priority, and we think that they should continue screening patients at the time of admission and getting the results back before you start the transplant. But we think you should continue. I mean, we had a patient in the last week who acquired COVID sort of about day +1 of her beam autograft, and from one of the members of staff, and we thought this was terrible things were going to happen. Very interestingly, she sailed through her autograft and engrafted very nicely at day +11, and was discharged home without any significant symptoms. However, about 4 days after discharge, she was admitted to her local hospital and has got infiltrates on her chest X-ray.
Wow.
So it was, it's early days. This has only happened over the last couple of days, so I'm waiting to hear. She's in hospital and relatively okay in her local hospital, but obviously it's a concern. But I do think that the risk sort of benefit probably in favor of high-grade lymphomas is to continue if you can get to that point.
Yeah. Okay. And another question regarding CLL. What recommendations for CLL patients with chest infection, not on active chemotherapy during these times? Quite general question.
Well, unless proven else, something else, they have COVID-positive patients, and that should be handled by ID people involved in COVID-positive care.
Yeah.
Yes, as I told you before, a patient nowadays, a patient with a CLL and some respiratory symptoms and with some imaging in the chest X-ray, in most cases is a COVID.
It's COVID. Yeah.
You have to treat as a COVID.
Yes.
Maybe just we had 2 patients recently, and one was myeloma, the other one I can't remember, maybe a leukemia person. They got double infections with COVID and Legionella. So it's not because you have COVID that you don't have something else, and people should be worried about that also.
I think that's really important. That's a thing that we've been trying to get through. You know, other infections are available at this time, and you know we need to remember that. And everybody's focused, particularly the neutropenic septic patients, about them being COVID, and we've got to remember all the other causes that we see in our general practice.
So your advice would be to exclude also other causes.
And although in the Chinese reports, apparently there were no further infections in the COVID-positive patients, we are seeing this not only in the hematological patients, but in all of the patients, we are seeing these further infections by bacteria, whatever.
So it's good advice. It's not to forget other.
And another important issue is I don't know in English, the pneumonia organizativa.
Organizing pneumonia, I think.
Yeah, it's not infrequent, and this would be an important problem for patients surviving the COVID.
Okay.
In some cases.
Are you saying as a
very
late
symptomatic?
Okay.
Yeah.
Okay.
We have also seen cases in New York of superinfection for people with COVID pneumonia with bacteria or even fungal pneumonias.
Yeah.
So just something to keep in mind is during the course of the infection to maintain a level of skepticism that you understand what the underlying infectious etiology is of decompensation.
Yeah, I think it's
I think another issue is that the PCR testing has a rate of false negative in nasopharyngeal samples for patients with pneumonia, which is probably in the range of 15-20% or something like that. Not all patients can get bronchoalveolar sampling and things like that. So we have some cases difficult. Obviously, our radiologists have learned very quickly what are the typical or so-called typical COVID lungs, but I think we have always to be a little bit worried because it can be fashionable, but we do know that pneumocystis carini also gives infiltrate and things like that.
Yeah. Next question. Any experience with hydroxychloroquine in these hematological patients?
Well, virtually all our patients gave the drug because it's one of the standard that actually have changed week by week or even day by day. The therapy of the COVID according to the infectious colleagues, but most of them are with hydroxychloroquine.
Okay. Yeah. Any other comments? No, everybody's using it.
No. It's patients on the clinical trial, testing 3 drugs against standard of care. There is a possibility to use it as a compassionate use, but we haven't prescribed it ourselves. So maybe for 1 or 2 patients that went into the ward, but it's scientifically it's not very well documented. I should say, because your colleagues here, that a few months ago I had a patient with CLL asymptomatic, stage B, low stage B, untreated, has developed Q fever with some mild inflammatory symptoms. And he's in the south of France, and he went to see a famous person that gave him hydroxychloroquine. So I don't know if it's a miracle drug for everything, but I'm skeptical about that.
For malaria, probably, but
it has an anti-inflammatory process. We know that for other patients, but whether it can help, that's fine. Let's wait. I think by the end of next week, we are supposed to have some results.
Okay, let us know anyways. And and this question is for Gilles also, because it comes in French. So I will try to get it right in English. The question is, low dose aspirin, is it contraindicated in patients with multiple myeloma in these COVID times?
That's a strange question. I know that right now there have been some reports of hypercoagulability states in patients infected with COVID because they have a very high inflammatory stages.
Yes.
The rules have changed in the hospitals. They all should be on low molecular weight heparin. So I won't stop any preventive measures in these patients right now.
Okay, I don't know if the question was specifically regarding aspirin. I mean, it was regarding aspirin, maybe because of the controversies regarding non-steroid anti-inflammatories, maybe some weeks ago. So maybe it was focused on that. And I have the last question now. Any experience with COVID and sickle cell disease? I'm not sure the question is for any of us. At least for me, it's not for sure. I cannot answer. But do you have any experience with sickle cell disease and COVID? No questions. No, I mean, no experience.
Nor have I seen anything published on the subject.
No, I don't think so also. Well, I got we are getting to the end of our time for discussion. I don't know if any of you wants to add any comments or information or share any other experiences that you're having. I don't think it's that different between our different places, just depends on the situations in the hospitals, I think. But any final comments?
I think these are obviously unprecedented times. We are learning a lot as we go along, and I think continuing to share information is really important. So I think forums like this are really very interesting.
I fully agree. I always learn a lot from all of you, and I intend to continue. If you share experience, I will be here to listen to.
I think we should really, besides science and clinical practice, always come back to people working with us, physical distancing, and all of that, because as Jose Maria was saying, I mean, we do see, unfortunately, infections in healthcare workers, some cluster of infections. So again, all people working with us, physicians and all the healthcare work, should be really making the maximum to get prevention of being infected themselves or being infected by patients or infecting patients. So again, physical distancing rather than social. I thought physical is better.
I agree. And with that, I think if no one has any other comments, I wish you a nice Easter, isolated at home, of course. Have fun during this weekend. For us, it's a long weekend, but it's a long weekend at home, of course. I don't know, and thank you all for your input and for the discussion, and thanks to our audience for the questions that they've been sending. I don't know if Susanna, who is our host today from Roche, do you want to end with any comments, Susanna?
I'm so glad that it was possible to have you in this digital meeting. I think our colleagues learned a lot with all the experience that you have shared with us. So thank you so much. And I hope you have a great, in these conditions, Easter. And maybe we can join all together physically and digitally in a next future.
Thank you, Susanna.
Thank you so much.
Thank you.
Thank you. Goodbye.
Bye-bye. Thank you.
And keep safe.
Yeah.
Bye.